I'm Dr. Stephanie Barrett, and I'm going to go ahead with the third webinar in the rheumatology series, which is looking at the similarities and the differences between COVID infection and rheumatic diseases. So I'm going to introduce my great friend, Professor Chris Denton, who's from the Royal Free Hospital, and his specialism is in scleroderma. Also, Chris is looking at many trials on the lung in scleroderma. So we worked together about 20 years ago on various aspects of the disease. Chris has also been on the wards recently, so he's going to walk us through the important things that he found on the wards. And after that, he's going to give a presentation. We'll do some questions and answers, and we'll cover the vasculopathy as well as the lungs. So I'm going to introduce Professor Chris Denton to come and join us.
So thank you, Stephanie, for this fantastic opportunity to be part of this RSM section of Rheumatology and Rehabilitation series, and really share with you, I think, some of my perspectives related to systemic sclerosis, which obviously I have a major interest in, and my more recently acquired experience of COVID-19. So just to give you a little bit, and perhaps people who are logged in, a little bit of context. So, for many years now, I've been running the large systemic sclerosis unit here at the Royal Free, and we've been undertaking a lot of translational and clinical research in systemic sclerosis. It's a huge challenge. We look after more than 1,700 patients with the disease. This is a cohort that we've built up over 25 years. What we had with COVID-19, of course, is probably in the last 6 or 7 weeks, about 1,700 patients with COVID-19 at least, where they were looking and caring for them at in the hospital. So a sort of uniquely different experience in terms of intensity. But just to say, my personal involvement in COVID-19 was that, like so many specialist colleagues, at the end of March, as the pandemic was starting, we were very keen to join our colleagues, and I went back into acute medicine to sort of share the burden, if you like, of the patients. And that was really, a feeling that there was a huge need. But in fact, as we started to see more patients, as I started to manage patients on the ward with COVID-19, it became apparent to me that there were quite a lot of similarities, even in the acute situation, between what we see in systemic sclerosis and this new disease. So, I think that's really what I wanted to share today in the webinar.
I said that you might sort of walk around the wards. So what were your first impressions when you were thrown in at the deep end?
Like many of us, I think, the first thought I had about COVID-19 was that it was going to be a viral pneumonia, and that a proportion of the patients got very severe viral illness and viral pneumonia, and that sort of ARDS type of pattern of disease, because I think that was the picture we had, from what we'd seen, I think, from other countries and perhaps from the early experience. Once we started to see the patients on the ward, it was clear that things were a little bit more complex than that, because we were particularly seeing patients who'd had their disease for quite a number of days. Often they were 7, 10 or 14 days into their illness, and they had often seemed to have gone through the acute sort of viral flu-like phase of the illness, and they were into a much more difficult time when it was immediately obvious that many of them were having a lot of respiratory problems with hypoxia, and this was perhaps something we were expecting. But when we started to look at the investigations, we were struck by the variability in things like the CT appearances, the chest X-ray patterns, and so on, with those sick patients, and then there were clearly different patterns of disease. And I think that's something that has emerged, obviously, over the last few weeks as people have understood more about it.
Yeah, thank you. So did you expect there to be such severe hypoxia in those patients? So it seemed as though reports were coming out that patients were very hypoxic, but not particularly breathless at the time. And that seemed very incongruous.
Yeah, so I think, again, this is one of the points I'll perhaps bring out when I go through my slides, it is about the diversity of the clinical situations that probably, was an indication that there are several different overlapping pathologies. So I think that is true, that we were struck that some patients who were markedly hypoxic seemed to be relatively untroubled by it, and we were much more worried about their low oxygen levels, and clearly they were at high risk, and we knew that some of those patients would do badly. So that was one group of patients, but then there was another group of patients that were much more classically, I think, distressed and they tended to be the patients that had some more radiological changes on their x-rays or their CT scans. So I think we immediately saw that there were sort of different patterns. And I think, to answer your question about the hypoxia, I think that when it became apparent that we were often dealing with a mixture of probably pulmonary vascular disease or potentially even thromboembolic disease, as well as the sort of parenchymal lung disease of the acute infection, that I think made more sense as to why we were seeing so much hypoxia.
Mm. And I remember asking you this weeks ago, and I don't think we could answer it, but in scleroderma, we always wondered whether it was the hypoxia, which was the driver of the fibrosis, or how it all fitted in, really.
Yes, so that's a great question, and I think we are well aware in systemic sclerosis that that hypoxia is an important modulator of the process, and probably contributes to, we think, the explanation perhaps why some of the involvements occur in particular organs related to vascular disease. But I think it is difficult to tease out the sort of specific role of cause and effect around hypoxia, other than that I think in damaged tissues where you've got a low oxygen tension, you certainly activate a genetic program triggered by that low level of oxygen, a sort of hypoxic associated response, which certainly can lead to fibrosis and scarring. And so that may be particularly relevant if we think about the longer term complications.
And in terms of the endothelial cell and endothelial cell activation and the cytokine storm, so you've got two models really with COVID and scleroderma. Are you going to talk about that a bit?
Yeah. So I'm going to cover that a little bit, I think, in my sort of thoughts about shared pathogenic mechanisms, because I think that's absolutely right. And when you'll see one of my slides of the sort of cytokine network that we would see as relevant to systemic sclerosis, and I've very clearly shown that in fact you could just take that exact same slide and talk through it in a slightly different way, particularly for that sort of inflammatory cytokine driven component of
yeah. So when we had Jess Manson was speaking to us about the cytokine storm, and do you think we're at a point now where we can look at a sort of algorithm, a set of triggers, red flags, where we could say, I know we haven't got the results of the tocilizumab trial, but where we could say now is the time to intervene with something which dampens down the reaction, the IL.
So I think that I think that is the case, and I mean I think that is the case in the sort of in concept, definitely, that that, as I said, it is a sort of clearly a multifaceted disease, and I would again, it's very important, I think, not to be oversimplistic in the sort of concept of what the disease is, because I think it's likely that there are components that are driving the process at different stages. I think there is definitely a subgroup of patients where you see clear markers of hyperinflammation, and we would say that those patients would particularly be likely, I think, to respond to or benefit from sort of anti-cytokine, anti-inflammatory type approaches. And as I will show you, I think there's a lot of parallel there between what we've seen in some of the subgroups of patients in systemic sclerosis that have responded to those approaches. So I think that's right. I think that one of the points is that COVID does seem to be a sort of a different disease. We can't just sort of superimpose our disease formats from other conditions. And I think we have to bear that in mind. So although there is clearly a hyperinflammatory process, I'm sure that Dr. Vance would also have pointed out that it's clearly not just a simple another cause of a macrophage activation syndrome like we might see in other diseases.
Yeah. Just before we move on to your talk, what do you think disturbed you or upset you the most about your time on the wards? Probably several things, but...
No, I think so. I think it was undoubtedly, as I said to you before we came online, I'm delighted to be giving this talk. I did my last shift in acute medicine, I hope, unless we have a second surge and I get redrafted into acute medicine. I did my last shift on last Saturday, and I'm very pleased to be giving this talk from the perspective looking back at COVID, if you like, which fortunately is not such a big problem now. It's really subsided in our hospital in terms of new patients. The thing that was most disturbing for me was seeing a whole ward where 27 out of the 30 patients had such a stereotypical problem of hypoxia, respiratory problems, and so on, who had all basically, or most of them, had sort of been well people 2 weeks earlier. And I think it's just was the intensity and number of patients, and the fact that I suppose, at least at the moment, the feeling that we were very much just giving supportive care, and in a way that's perhaps something to understand, that what we need to be able to do probably for the future is to be able to, as you're suggesting, intervene in the disease process, and identify which patients need which approach at the right time. But I think it was just the intensity and number of patients, and the fact that we were really just offering a supportive approach to most of them.
And it wasn't the stereotype of inside over 70s, or
not absolutely not. And of course we all had a different snapshot of the patients. I was looking after the ward patients, which are clearly not as sick as the patients going to ICU, but no, we had a complete spectrum of age and gender, in fact, and ethnicity. So I think perhaps that's a reminder that the disease is perhaps less discriminatory about who it affects, and even who it affects quite badly, but perhaps it's what happens when you get that more severe illness that is the determinant of your mortality and ultimate outcome. And that, I think, is perhaps a good point to move to the concepts that I will hopefully bring out a little bit in the presentation.
Brilliant. Well, let's go ahead with your talk then, if you would. Thank you.
I'm going to give a short presentation, really following this title, that is just this really focus, I think, especially on the respiratory aspects of systemic sclerosis and the parallels with COVID-19, but thinking a little bit more generally. And I will be following on some of the points that we just discussed a little bit in the introduction. So these are my disclosures, which are all really related to work on drug trials and drug development in systemic sclerosis. So it's encouraging that there is so much interest from partners in the pharmaceutical industry, just as there is, of course, now in COVID-19. So this is really the top level of what I thought that we would be covering in this presentation. That the similarities, the shared features between COVID-19 and systemic sclerosis are, first of all, that we are dealing with a complex multi-system disease in both cases, but with a predominance, I think, of vasculopathy and lung complications, and some of that occurring within the lung. I think in both diseases, as we discussed in the introduction, we're dealing with a condition where there are some patients, in fact, perhaps even the majority of patients, who have relatively milder disease. And this is, of course, good news for patients. But there are a subgroup of patients where this is a lethal disease in both cases. And it's about trying to understand what determines really whether you have a lethal, very severe form of the disease, or whether you're in a milder subgroup. I think there are some shared points that everyone will be well aware of. I think that men do worse with systemic sclerosis. In fact, some ethnic groups do worse in systemic sclerosis, and there are parallels there, and that may link to pathogenic mechanisms potentially. And then I want to just highlight a little bit the work that has been done over the last few years, really focusing on interleukin-6 as a key driver in severe systemic sclerosis. Some very positive data coming from trials of blocking IL-6 in systemic sclerosis, and of course the interest of blocking IL-6 in COVID-19. So I just wanted to give 2 or 3 slides just to remind those of you who may be less familiar with systemic sclerosis about the comparator disease, if you like. So here are some of our patients with systemic sclerosis. It's an uncommon or rare disease, but not ultra rare. So about 1 in 10,000 patients or individuals in the UK develop systemic sclerosis, giving it around the same frequency as primary ANCA vasculitis or primary idiopathic inflammatory myopathy. So it's in that group of immune-mediated rheumatic diseases that are uncommon but not ultra rare. Like most autoimmune diseases, it's commoner in women with a 4:1 female to male ratio, and it tends to have an average age of onset at around 50, but in fact it can affect you really at any age in your adult life. And the key thing I think that's really important to put into context is that 50% of our patients that we see with systemic sclerosis unfortunately will eventually die as a direct result of their systemic sclerosis, of their connective tissue disease. Of course, now, unfortunately, compared to 30 years ago, patients are living much longer, so we're now looking at much more survival in systemic sclerosis, but still, ultimately, many of the patients will die from the disease. And I think that's a very important context to think about diseases like COVID, where, of course, because we had such a large number of cases in the pandemic, we had a fearful number of deaths, but actually as a proportion of the patients with the disease, compared to a condition that's sort of lifelong and like systemic sclerosis, the proportion of patients that are going to ultimately die from it is obviously much smaller. We can differentiate just in the clinic between what we might think of as milder and more severe forms of systemic sclerosis, just as we might differentiate a milder and severe form of a case of COVID. In terms of skin involvement, we know that about 1/3 of our patients have very extensive skin fibrosis, as you can see in the gentleman on the left with diffuse cutaneous disease. The other 2/3 of patients we see have much less fibrosis in the skin. They have the more limited form of the disease. But it's very important to remember that it is a systemic disease, and whatever's going on the outside in the skin, you're at risk of developing any of these internal organ complications that I've summarized on this clinical slide. And of course, particularly relevant to the talk today are the patients who get lung fibrosis, pulmonary vascular disease, cardiac involvement, and renal involvement in their scleroderma. Although these complications can occur in either of the two subsets, we've really recognized over the last 20 years or so that you can certainly distinguish patients that are at different risks of the complications. And to some extent, patients with the limited form, the milder skin disease, are less prone to develop those major heart, lung, and kidney problems, but they still occur. And because limited scleroderma is actually much commoner than diffuse disease, when you look numerically, in fact, we often see as many patients with limited scleroderma with bad lung problems, for example, as we do diffuse. But just as we might think about the COVID population of having sort of patients who have major involvement, having a high mortality, and those with milder disease less so, the same is true for systemic sclerosis. And this is a survival curve that is where we've just superimposed those patients with or without major heart, lung, or kidney problems. And what you can see is even if you have mild skin disease, if you do have heart, lung, or kidney problems, lung fibrosis, pulmonary hypertension, your survival is just as poor. So an important point that we need to think about more sophisticated ways probably to try and identify patients who are particularly at risk in scleroderma. But that background of a high burden of major life-threatening organ-based complications was really perhaps the first intersection between systemic sclerosis and COVID-19, because I think as physicians who manage this very difficult disease, we were particularly worried about what would happen to our patients when they were exposed to COVID-19, and this was true across the world internationally. And so, right back in the beginning of the pandemic, a number of experts from around the scleroderma centers, really representing Japan, Europe, North America, and the UK, we all came together really to think about what would this disease mean for our patients. It came up with this publication, which is really a roadmap just advising and considering the different aspects as were known at the time of COVID-19 and what that would mean for scleroderma and where we might be particularly worried. And of course, it highlighted the need to try and really avoid COVID-19 if you had major organ-based complications or you were on a major immunosuppressive drug. So this was the sort of context at that time. But as I started to look after patients with COVID-19, I think I became much more aware of the similarities and shared sort of clinical features, and the shared clinical challenge, if you like, of looking after a ward of COVID patients as opposed to a ward of systemic sclerosis patients. And the similarities I've sort of listed here, and I'll just sort of think about it or just highlight it a little bit more. So I think we were all expecting that we would see quite a lot of parenchymal lung disease, a viral pneumonia, a sort of secondary inflammatory lung disease, co-infection and secondary bacterial pneumonia, which is recognized as often occurring in, particularly in these later stage COVID-19 patients. And here you can see some cross-sectional imaging showing the sort of typical parenchymal changes are seen in COVID-19. But of course, that's something we're very familiar with in systemic sclerosis. As we saw more and more patients, it became apparent, and there's some lower to CT scans and some CTPA studies done on our COVID patients here at the Royal Free. And you can see that not only do we see the parenchymal lung disease, but if you look here, you can start to see evidence of thromboembolic disease and pulmonary vascular disease as part of the clinical problem. And then it really started to become apparent why we were seeing some patients who were so profoundly hypoxic, even sometimes without very much parenchymal lung disease, because we found, as other centers have, a very high frequency of pulmonary thromboembolic disease in our COVID patients. As we saw more and more patients, in fact, I started to see some other features that I was quite familiar with, and that was we started to see evidence of peripheral digital ischemia in a number of patients. Here you can see again, the upper photograph is the hand of one of our patients with COVID-19. Very clear evidence of acrocyanosis of, you can see some subcutaneous changes there that we recognize as very typical of ischemia, and often sometimes quite critical ischemia in the digital vascular circulation. We see this in lupus vasculitis, we see it in systemic sclerosis quite commonly. And although I don't have a picture from my own clinical experience, you may well all be aware now that the so-called COVID toes or perniosis associated with levator reticularis and poor circulation is well recognized now in occurring in quite a proportion of patients with COVID-19. So, you know, it starts to suggest that in addition to the other complications of the disease, a systemic vasculopathy and perhaps a microvascular abnormality was occurring. I think another important thing that's clear is that the mortality of COVID-19 disease is primarily driven by lung, kidney, and heart involvement. And there, of course, we've got a similarity with systemic sclerosis, where we are very familiar with the fact, and here's one of our patients with scleroderma, that illustrates a sort of a group that we're particularly concerned about in systemic sclerosis, but also that we're obviously quite concerned about in COVID-19, namely a male patient of African-American or Afro-Caribbean origin. And we know that this group of patients are particularly prone to the major complications of systemic sclerosis that impact on mortality, and that is one of the reasons why men in particular and Afro-Caribbean men have a particularly high mortality in scleroderma, and it's due to the interplay of the processes that drive the disease that seem to be particularly severe in this subgroup. So I wanted just to think a little bit about, you know, how we can learn perhaps from what we've been working on over the last few years in a rare disease like systemic sclerosis, and what we can sort of draw parallels with when we're trying to think about aetiopathogenesis, not just of the disease, but also of the complications of the disease. So if I first of all put the reference slide up for systemic sclerosis, so as I've said, we're dealing with a disease that is infrequent in the population. So we know that whatever is responsible for causing systemic sclerosis, it does occur relatively infrequently, 1 in 10,000 in the UK. We know that it occurs at a particular age, and for what that, I think what we would take from that in a complex disease is that it does suggest that multiple things probably have to happen and come together to cause the disease or trigger the disease in a particular individual. We know that 80% are female, so we know that that sort of fits in with the general feeling for autoimmune disease. But we know that the disease, as I've suggested, is very diverse, and we've done a lot of work to try and understand that diversity. I'll share a little bit of that with you just in a few slides. But again, we know that men do worse. We know that Afro-Caribbeans and African-American patients do worse. But for any disease, if we're thinking about what is the etiopathogenesis or the etiology of disease, we of course have to think about, I would say, three factors. The first is the host susceptibility, and I think the easiest handle on that is the genetic susceptibility, although clearly epigenetic factors are also very, very relevant. But we know in scleroderma that there are clear genetic associations that make you more prone to the disease, and I will talk in a little bit more detail about some of those. But we also know that its interplay with the environment's important, and we know in scleroderma that we can, in some patients, very clearly identify a trigger for the disease, whether that be an organic solvent or silica dust or vinyl chloride monomer, heavy metal exposure, a whole range of things that we know in an individual patient seem to be important in triggering the disease in a susceptible individual. But that really brings back to the thing that is often overlooked, I think, when you're thinking about etiopathogenesis of any disease, but in particular a disease like systemic sclerosis, and that is chance, because these triggers and have to come along at the right time in the right context, and that may underpin some of the sort of associations that we see with stress, with family changes, with all sorts of things that we see in the disease. So if we're thinking about systemic sclerosis, and you can sort of come together with a construct like this, a susceptible individual, multiple things happening over the course of perhaps 10 or even more years, where the patient first goes perhaps through a pre-scleroderma phase where they might just have Raynaud's phenomenon, and then they develop some vascular abnormalities and early scleroderma features, and then they develop systemic sclerosis. And we imagine that this is a consequence of the environmental triggers that we're exposed to, or our patients are exposed to, in someone who is susceptible. But just as for COVID, what really matters when you get the disease, as I've shown you, is what happens and what complications you get and whether they are severe or mild. And that's, again, where we think that there are a lot of host factors involved. And it may be this area that we could perhaps draw the best sort of parallels with a disease like COVID-19. So if we just sort of look now and see how that sort of concept can be shared across the two diseases. So, we don't have very robust demographics and epidemiology yet on COVID-19, but we do think that this is a highly infectious pathogen, that when it's spreading within a population, there is a very high risk of being exposed and a very high risk of contracting the disease. I think the most recent estimates based on serological assessments suggest that that probably in London, for example, at least 1 in 8 of the total population have probably now been exposed to COVID-19. So that's way fewer than is needed to properly establish herd immunity, but it's a significantly large number of the population. Again, we know that it's a diverse disease. We know the same points are important. If you're male, you are likely to do badly. If you're Afro-Caribbean or African-American, you probably are more likely to do badly, and that's true for some other ethnicities, as we know. But if we're thinking about that same interplay of factors, in fact, the most important thing, thinking about the etiopathogenesis of COVID-19, whether you're going to get it, is chance. So this really emphasizes the point that if you don't get exposed to the pathogen, you won't get the disease. And really it highlights the critical things that we're doing at the moment. Lockdown, social distancing, hand hygiene, PPE if you're working with COVID patients, and of course shielding for our patients that are at high risk. Because really, unlike the complex concept of a disease like systemic sclerosis, the only thing that really matters to get COVID-19 is exposure to the SARS-CoV-2 virus. But where we think the host may be more important is determining what happens to you once you get the disease. So really, I think we can have a much more simple construct of how we could put those sort of concepts of systemic sclerosis into COVID-19, because we're dealing with essentially a common infectious disease where if you're exposed to it, you're highly likely to get the disease. There's not a concept that you need to have very specific factors to get the condition. But once you've got the disease, it's probably host factors, and that may include many genetic factors that determine how you get the disease, how bad it is, and how badly you do. So really that was sort of concept that I just wanted to go through now of thinking about those shared pathogenic mechanisms, and maybe whether we can take some lessons from what we've learned of the concept of systemic sclerosis, because although we don't understand the etiology of systemic sclerosis, I think we have a much better handle on pathogenesis than we used to. We know that certain things can trigger the disease, and we know that a number of factors can operate that seem to determine the outcome, and we know that gender and ethnicity are important. We know that comorbidity is very relevant in terms of outcome. So in systemic sclerosis, it's taken a long time to collect enough patients to do sort of very powerful genetic studies, but we have now done those. And so just last year, we published this meta-analysis of more than 9,000 systemic sclerosis patients, which really gave a very good insight into the genetic landscape that made you susceptible to scleroderma. So this is a Manhattan plot for a genome-wide association study in systemic sclerosis, a meta-analysis of a number of independent cohorts. And what this showed us was the genes that really make you susceptible to develop systemic sclerosis. And the big peak here is in the HLA. So the immunogenetics is the most dominant factor as to whether you're prone to get scleroderma. But all of these other genes are also relevant. And if any of you are geneticists and recognize them, you will see that many of these genes are in fact genes of the innate immune system. And so that's very interesting because it suggests that factors that are just responsible for responses to tissue damage and inflammation, so not highly regulated adaptive immune system genes, seem to be what determine your risk of developing systemic sclerosis. And what's interesting, of course, is this overlaps with many, many other autoimmune diseases that we see. What I think has been more interesting has been the ability to start to look at the individual subgroups of scleroderma, whether that's limited or diffuse skin disease or different autoantibody groups. And there we can again start to see genes that really determine which sort of scleroderma you get when you get the disease. And this is where I think we could draw an analogy with something like COVID-19. It may well be that there is a genetic landscape that will determine when you get the disease whether you are more or less prone to develop lung complications or vascular complications, or indeed have a very mild form of the condition. In systemic sclerosis, we have the additional advantage that over the years now, we've really refined our understanding of the antibody markers that we can look for in our patients to such an extent that now, in fact, we understand that all of our scleroderma patients essentially develop antinuclear antibodies, but within the disease, we see actually a family of antibodies that are more or less mutually exclusive, meaning that if you have systemic sclerosis, you will really just develop one autoantibody and not another. And what's interesting is those different antibodies relate to risk of developing complications. And I'll show you two examples of that. And where that is interesting is that we know that the main determinant of the autoantibody you get is your immunogenetics. So it comes back to the HLA region. Your class 2 MHC haplotype determines essentially which autoantibody you get. And therefore, it's almost genetically determined in a way what form of scleroderma you might get when you get the disease. And you can see that if you're unlucky to have this anti-scleroderma 70 antibody, independent of limited or diffuse skin involvement, you have a hugely high risk of developing major lung fibrosis, as you can see here in this plot. So we can take that concept of using the antibodies to sort of refine some of the genetics a little bit further. And here in work that we've literally just published has taken another antibody that is associated with scleroderma renal crisis. So this is the anti-RNA polymerase 3 autoantibody, which gives you a 10 times increased risk of scleroderma renal crisis. So if you have this antibody and you have scleroderma, you have a very high risk of getting a life-threatening hypertensive renal failure complication. But what was interesting is that if we just took those patients that had renal crisis with this antibody and we compared them genetically with patients who never had a renal crisis but had the same antibody, this was a way, if you like, of correcting out all of that immunogenetics and coming back to look at what was the true genetic susceptibility to the complication. And again, this work just published online, but I'll just highlight that we found two genes we thought that were very relevant and very interesting. The first of those was in fact a gene that had already been identified as a susceptibility gene for diastolic hypertension from many of the large hypertension studies. So what that tells us is if you're going to get a hypertensive crisis in scleroderma, you are likely to be a patient who's susceptible to hypertension anyway. So that is interesting because it's an independent risk factor. And the other gene that we found was a gene that was related to Wnt signaling, which is related to connective tissue repair. repair and vascular repair. So it suggests that these patients, and this was a negative regulator of the Wnt pathway, and suggests that patients with renal crisis may be less able to repair their vascular injury. So that was just a sort of couple of examples, but then you can put all of those things together into this sort of schematic. And this was a schematic that one of my very talented fellows put together a few years ago for the cytokine and cellular pathogenesis of systemic sclerosis. And you will realize that it's got all of the key players here of the innate and the adaptive immune system. It's also got epithelial cells and endothelial cells and fibroblasts and myofibroblasts all together, a sort of immersed, if you like, in a cytokine soup that could be driving the pathology. And what I realized when I re-looked at this slide was that you could very much superimpose that exact same sort of concept and framework of cellular interaction and cytokines if you're thinking about the immunopathogenesis of COVID-19, and particularly the immunoinflammatory problems that we see in the blood vessels and in the lung. So with that in mind, I just want to sort of give the final part of the talk, which was really suggesting that with that rationale, it's not surprising that some of the drugs that are being talked about and even being tested in COVID-19 are drugs that we're very familiar with in systemic sclerosis and in rheumatology. So I've put a list here of 5 drugs just to highlight that as examples. I don't want to go into great detail about hydroxychloroquine because that is clearly a very contentious drug. There have been some studies that have suggested it may accelerate viral clearance, but I think the data is definitely not clear. And the advantage that it gives you in terms of reducing your susceptibility to catching COVID-19 is definitely unclear and unproven. There's some interest in steroids because obviously in any inflammatory situation, steroids could be helpful, but there are clearly concerns about giving corticosteroids in the context of a systemic viral infection. And so that's something that is, I think, being studied further, and I think that's appropriate. Interferon beta I just mentioned because it is being included in some of the clinical trials for COVID-19. And a few years ago, we were certainly interested in that as a potential treatment for systemic sclerosis. We never undertook a phase 2 trial, but we were certainly interested in that because, of course, it's beneficial in multiple sclerosis, which is another immune-mediated inflammatory condition with some pathogenic parallels. But I just wanted to highlight 2 drugs that we routinely use in our connective tissue disease patients that I think might have some promise in COVID-19. And the first is tocilizumab, and the second is prostacyclin. Prostacyclin we use very much for treating the peripheral vasculopathy of scleroderma, and we use it sometimes for the internal complications like renal crisis. We used it in several of our patients who had that peripheral ischemia in COVID-19, and we were impressed that it not only seemed to improve those symptoms, but in those patients at least may even have improved their oxygen saturation and reduced their oxygen requirement. It was just a handful of patients, and so clearly more evaluation would be needed. But I know that prostacyclin was something that is also used in other situations in our intensive care unit and other units to treat the sick patients because of its potential benefit in the pulmonary circulation. But tocilizumab is the drug that I really wanted just to focus on because for the last few years, we've been very interested in the potential for IL-6 to be driving our most severe cases of systemic sclerosis, those patients with diffuse cutaneous systemic sclerosis at particular risk of heart and lung disease. And so this is something we've been working on for a number of years. So, the first observation was that we noticed that patients often had elevated IL-6 levels in their serum, and that was associated with a poor survival. So patients that had low IL-6 levels did well. Those patients with high IL-6 had a poor survival. We associated it with bad skin disease, but we knew that they were not dying of their skin disease. So we looked more carefully and we found evidence of expression in the kidney and in particular in the lung tissue of our patients with severe scleroderma. And in a very nice complementary study done with colleagues at the Royal Brompton Hospital, we were able to show, in fact, that your IL-6 level in early stage scleroderma lung disease was very predictive as to whether you were likely to progress or not. Interestingly, it didn't seem to be relevant once you had severe lung fibrosis, but it did seem to be particularly important in that early stage of the disease. And therefore, we were very interested to think whether blocking IL-6 could be helpful in scleroderma, but especially in the early lung fibrosis of scleroderma. And this led to 2 clinical trials, a phase 2 trial and now a phase 3 trial. This trial, I'm pleased to say, has just been accepted for publication in a high-profile journal, so we'll look forward to sort of sharing the full data from the study. It's been presented at a number of meetings, but essentially what this trial, which recruited more than 200 diffuse systemic sclerosis patients, showed was that in early stage lung fibrosis, so these patients all had relatively mild lung fibrosis, but if you followed them for a year on placebo, you had a very significant decline in their lung function. If they're on tocilizumab, you essentially prevented that completely. And why that is important, of course, is that if you could prevent the patients developing the problem, that could be, a much more attractive option when you don't have so many treatments for established fibrosis. So these data are exciting. We spent quite a number of months convincing referees of the journal that we were genuinely seeing an antifibrotic effect. And just to, if you relate this back to what we saw in the CT scans for the COVID patients earlier in the presentation, these are patients that went into the tocilizumab trial. These were early stage scleroderma patients. You can see very clearly at baseline quite extensive lung fibrosis here at the bases of the lung. What was encouraging, here are just 2 examples. Those patients on placebo unfortunately showed progression of the lung fibrosis. Those patients on tocilizumab in fact showed significant improvement. I should say we carried on with an open label extension, and we're very pleased, we're going to be presenting that soon, that in fact we did see further improvement of the lung function in those patients after we'd switched them to tocilizumab. But these data were all actually analyzed quantitatively using a very robust quantitative CT scoring system. And essentially, when you look at the extent of lung fibrosis scored, you can see for tocilizumab, it always went down, and on placebo, it always went up. So these are very robust signatures that suggest that tocilizumab is very good at blocking the early progression of lung fibrosis in scleroderma. And why this, I think, might be particularly relevant to COVID is that we think this is a stage where there is an interplay between inflammation and fibrosis, and that's the point at which we're intervening. We are seeing a genuine antifibrotic effect, but it's probably because we're treating the inflammatory cells that are producing a lot of IL-6, as well as TGF-beta, and driving this fibrosis. So we know that our patients with poor prognosis scleroderma have high levels of IL-6 in the skin. We know that it's in the lung and the heart. And in this study, which we published a couple of years ago now, we couldn't study the lung fibroblasts, but we did study the skin fibroblasts and showed very clearly that we could reverse the pro-fibrotic activity of these fibroblasts after we treated the patients for 6 months with tocilizumab. So it's exciting to think that tocilizumab could be useful in scleroderma. It could be relevant to COVID, and as I'm sure you're aware, there are trials now ongoing. There have been case reports and observational studies that are encouraging. But 2 studies I would highlight. The large Roche-sponsored study that's fully recruited now, 350 patients, is the COVACTA trial. And also in addition to the COVACTA trial, which is you can see here on the clinical trials website, I'd also highlight the very interesting recovery trial, which is a very large adaptive trial being led from Oxford. And this has now added tocilizumab as to one of its treatment arms. So I just wanted to finish with a couple of slides just to highlight, as we talked about at the beginning, that it's clear that patients with COVID-19 are doing very badly, and they're not just doing badly because of their parenchymal lung disease, their lung inflammation and potentially fibrosis, but also because they're getting thrombotic and potentially pulmonary vasculopathy as well. And this is exactly what we see in scleroderma. So if you don't have a lung complication, your survival is quite good. If you have lung fibrosis, it's not so good. If you start to get pulmonary vascular disease, it is worse. But this group of patients that are very unfortunate that have pulmonary hypertension, so pulmonary vasculopathy and fibrosis, do particularly badly. And we think this may be very relevant to COVID-19 because just as in COVID-19, we do recognize that our patients with scleroderma have pulmonary vascular problems. We sometimes see, as you can see here, there's a scleroderma patient with a very large proximal pulmonary embolus, and here is a patient with more distal pulmonary embolic disease. But what we were also struck by in our scleroderma patients is something that we think may well be operating in the COVID-19 arena, and that is that when we did some studies using a very precise technique of optical coherence tomography to actually visualize the lumen of the pulmonary arteries, the relatively small pulmonary branch of the pulmonary artery, we could see very frequently evidence of mural thrombus. So in scleroderma, which is a disease where we know we have endothelial cell activation, we very often see evidence of this mural thrombus if we go looking for it in the pulmonary circulation. And we think this is one of the mechanisms by which we get pulmonary vasculopathy and pulmonary hypertension in scleroderma. But of course, we really think that this may also be operating in COVID-19, where there is clear evidence of generalized endothelial cell activation. And we think in a number of patients, evidence of intrapulmonary thrombosis and benefit from anticoagulation and potentially from other treatments. So this is my final slide, and I just wanted to hope that I shared with you some of my experience and parallels that I think we could draw between systemic sclerosis and COVID-19. One of them being that it's, you know, extremely severe in a minority of patients. I think it's interesting because what we've seen in COVID-19 clearly is a sort of simultaneous stimulus of the population with the same trigger, but that some of the factors that determine outcome might be the same sort of factors that operate in a complex, rarer disease to determine whether you get lung fibrosis or pulmonary hypertension, for example. I think the nature of the immune response, the response to the injury when it occurs, including the hypoxia, and the consequences of having generalized endothelial activation in the context of a viral infection, or of course a connective tissue disease, may be relevant. And I just highlighted, I think it will be exciting to see whether IL-6 has a beneficial effect in COVID-19. So I will finish there. I'm very happy to take any questions that you've had sent in.
Yeah, really brilliant. Thank you so much. I mean, really helpful. How many of the respiratory physicians have noted all of these things or know about the scleroderma parallels?
So I think first of all, I would say that I think in those patients managing COVID-19, I think we've been working very much as a multidisciplinary team at the Royal Free, and that's been one of the joys, really, I think, of working with so many expert colleagues. And I know that's the case in all of the major hospitals across London, and I'm sure elsewhere through the UK. So I think looking after COVID-19, we're all aware of this interplay between pulmonary vasculopathy. It became increasingly realized that the thromboembolic disease and probably intrapulmonary thrombosis is an important element, and there's been much more of a focus, I think, on anticoagulation and dealing with that. So I think that's appreciated in terms of COVID. Scleroderma, I think, it has been a learning curve. It certainly was a learning curve, I think, for pulmonary respiratory physicians to understand potentially the relevance of an inflammatory process to the determining what is a fibrotic.
Yeah, that's what I was thinking. Yeah. And how many patients did you see go on to develop or leave hospital with severe lung fibrosis from the current your current experience on the wards?
So I think we've arranged follow-up clinics for our COVID patients. Some of that is a sort of just a follow-up, particularly in those patients who had more severe disease. So I think we will have to wait and see, because you would expect, I think, for any of the patients even with relatively acute lung injury, it will take a few weeks and maybe even a few months to recover. I think our concern, and in fact, we've set up a prospective trial with Jerry Coughlin, who's one of our pulmonary hypertension physicians, leading it to really look in the longer term at some of those patients to see whether they do develop pulmonary hypertension or indeed pulmonary fibrosis. We know from SARS, for example, from the SARS-1, that about 10 or 15% of patients did develop lung fibrosis. And I know anecdotally from talking to colleagues at the Brompton that they're starting to see a few patients who had lung fibrosis where it's been aggravated after COVID-19 infection. So I think this may be a problem for the future, but I really think it's going to be 6 to 12 months before we get to sort of, know whether that's a reality.
And can we just go into the digital vascular problems in COVID? So what stage do they generally come on, the sort of acute blue finger? So is it late or is it early, or what's
so these were all the patients that we saw with this were all patients who'd had disease for at least 2 weeks. So I would see it as part of the later phase of the illness. And, I think for me, the clinical context was actually, rather than being more like systemic sclerosis, it was much more to me like a sort of lupus vasculitis or even a chilblain lupus type of phenotype. So I think it probably related to endothelial activation and inflammation, which is, and so of course that's very fascinating, because I'm sure hearing now about the Kawasaki phenotype in children, which again is obviously, we recognize as a disease which is often has a viral trigger and is associated with endothelial activation and inflammation. So maybe it's a similar sort of process.
And are they generally self-limiting? So digital blue finger, or toes, are they self-limiting, or do you treat them? What's the sort of...
So outside the context, I think outside the ICU context, we certainly didn't see any critical ischemia or gangrene or serious ulceration. We did treat a small number of patients with intravenous iloprost, which we do in other contexts. And we have written that series up to try and publish that experience, because I think what was interesting was that we did it for the peripheral vasculature, but we did of course have very detailed oximetry, and those patients did, obviously it's uncontrolled, but they did all seem to certainly not be disadvantaged by that. And we wonder whether that was something that could be considered in the future.
I was wondering about that.
For other patients.
Yes. Okay, great. Well, I think we're almost running out of time, but I'm just going to, oh yes, somebody else has asked about the fibrosis, the cardiovascular and autoimmune, consequences later on. Do you see that that's going to continue, or is it self-limiting? What's the kind of feeling with a COVID patient who's got a severe attack in the lungs?
So my expectation is that there'll be two sort of situations. One is that some patients will have had severe organ damage as part of the acute illness, and that may or may not recover, and that would be, as with other forms of lung injury. I'm particularly interested though with the thought that it may be that in some patients, just as we think a systemic viral infection may be a trigger in some patients of idiopathic systemic sclerosis, that maybe it will trigger a later autoimmune process. And I think one of the concepts that we're learning in scleroderma is it's often not the turning on of the disease that determines your outcome, but it's your ability to turn off the process. And that, I think, is where you can perhaps draw an analogy that it's possible that some patients will have more difficulty switching off, even in the longer term, some of those tissue damage responses. But I think we just have to wait and see. But it's certainly something that we're interested in. And with regards to scleroderma, obviously there will be careful observation of patients all of us who've got scleroderma cohorts will carefully watch our patients who have had COVID-19 to see how they fare. So
do you see yourselves at the Royal Free maybe setting up a clinic to follow up these patients if indeed they do exist?
I think we're mindful. I think
a combined clinic.
So the real challenge at the moment, I think, is just re-establishing our large scleroderma clinical service, and I think that's true for all important diseases. And we have to remember how lethal systemic sclerosis is, and how we really focus on that. But I think there are certainly COVID patients that had severe disease will need some degree of follow-up to see whether they're in a risk group. But I think that's probably something that we will see. I think from our point of view, we will see within our practice that we know that obviously a proportion of patients have had the illness, and we'll see how that
okay. I think we've run out of time, Chris. So thank you so much. That was so comprehensive, unexpectedly so, given the pressure on everyone's time, and but very, very good.
And thank you very much. Great to share my thoughts.
It's brilliant. Thank you.
Thank you very much.
We might get you back do another bit. Thanks so much.
Thank you.
All the best. Bye. Bye.